Good morning. It's my pleasure to introduce our guest speaker today, Dr. Mark Malangoni. Dr. Malangoni grew up in Indiana. He went to the University of Indiana and completed his medical and surgical training in Indiana. Dr. Malangoni's been a leader in American surgery for at least the past 3 decades. He was, for 20 years, he was a professor at Case Western Reserve and chair of the Department of Surgery at Metro Health in Cleveland for more than 20 years. Dr. Malangoni is really sets at the interface of American surgical education. He's currently a member of the Board of Regents of the American College of Surgeons. He's been the chair of the Advisory Council for General Surgery, the chair of the Board of Governors of the American College of Surgeons. He also has served in the leadership of the Residency Review Committee for Surgery. He's past president of the Central Surgical Infection Society and the Ohio chapter of the American College of Surgeons. He's been in the leadership of the American Surgical and currently serves in leadership role of the American Board of Surgery and is also serves on the American Board of Emergency Medicine. He's a scholar, has published over 200 peer-reviewed publications, numerous book chapters. I think it's fair to say that there's probably been more change and controversy in the past 10 years of surgical education from any time except in the beginning of the 100 years of modern surgical education. And he has really been at that interface between the American Board of Surgery, the American College of Surgery, the RRC, and the program directors. And he's been a voice of reason and wisdom, and it's my pleasure to introduce Dr. Malangoni, our guest speaker today.
Well, thank you, Dr. Stewart. That was a very nice introduction. I really appreciate it. We were reminiscing about the last time I was in San Antonio on the campus, and it was a long time ago. Old hospital, smaller city, some of the same faces. So it's really great to be here and see everyone again. So this morning I'm going to talk about surgical education and what some of the challenges are. And hopefully we'll have a very vigorous discussion afterwards. I'd like to hear your opinions about all of this. And we'll start out by reviewing some of the history of surgical education, what's happened with regulation change over time and some societal expectations that have really affected residency education, to talk about some of the tensions that are still out there and hopefully at the end identify some gaps that need to be filled and come up with a few suggested solutions. So let's start with history, and I'm going to just start with this quote because I think it's so applicable to so many things that we do in life, and that is, those who cannot remember the past are condemned to repeat it, by George Santayana, and very, very important to for all of us to remember. Those good ideas tend not to be novel. So surgical training, at least beginning in the 1800s, was somewhat disorganized. Medical schools were trade schools. Anyone could start a medical school. All you needed to do was to give a diploma at the end and usually charge some money and create a relationship between the student and someone else. The curriculum was not standardized. Teaching hospitals were extremely rare. The training, as you can imagine, was very variable. Operative experience was limited. Usually you were watching or you were helping. And if you think about the operations that were done back in the early 1800s, there weren't many, and most of them were done on extremities. Anesthesia and asepsis were not accepted until at least halfway through the century, and those two things in itself had tremendous change in our surgical care. The specialists were often thought of as charlatans, and that was problematic, and there was really no association for medicine until about the mid-1800s. So the Civil War came along, and we all know about the issues related to that, but I want to just speak to medical care during the Civil War. So there were few trained surgeons, but there was a great need for physicians in that time. We think about the deaths that occurred with the major battles, but the real problem were the casualties that occurred which often exceeded the number of deaths by 10 times or more. A lot of the experience was gained on the job. Everyone expected that there would be experiential learning. It was not see one, do one, teach one. It was see one, do more. And there was a recognition at the end of the Civil War that there was a need for licensure of medical specialists and medical practitioners, as well as for training programs. Well, William Stewart Halsted came along, and I think we're all familiar with the Halstedian model of surgery. It was established more than 120 years ago at Johns Hopkins Hospital. Halsted's goal was to train professors of surgery who were to populate the United States and be professors and heads of departments of surgery at medical schools. The structure was defined. There was much more of an emphasis on clinical practice and not so much on basic science. You had to have a chief residency, that year of independent practice prior to finishing your residency, and it was a very autocratic system. We know about the monastic characteristics, but more importantly, it was extremely inefficient. So in Halsted's 32 years as chair, he trained 17 chief residents. So not the way you're going to fix the need for surgeons across the country. If we look at the influence of Abraham Flexner and the landscape for medicine around 1910, Flexner identified in his report that there was a critical lack of hands-on experience in medical education. Interestingly, the idea of hands-on education was not adopted in residency training. And at that time, there were very few residency positions for medical school graduates. Most physicians didn't do a residency. They finished medical school, went out and went into general practice. And the AMA, remember, our society, the American Medical Association, was very resistant to having specialists at that time. Well, the board movement started actually 101 years ago with ophthalmology, and the American Board of Surgery came along about 30 years later and used these criteria in order to become board certified. Now, these criteria are not new. They were the same used by the American College of Surgeons to become a fellow of the college. Okay, so the big change, though, that occurred with the American Board of Surgery was that there was an examination or a set of examinations that one needed to pass in order to become board certified. And this was an attempt by specialists to set a higher standard for calling yourself a specialist by obtaining board certification and to distinguish yourself from anybody else who went out and said, in this case, I'm a surgeon. Now, there's some other events that occurred in residency education that I think were exceedingly important. The Residency Review Committee, which oversees all training programs in the U.S. today, was created in 1950. Medicare was established a little more than 50 years ago, and with the establishment of Medicare, there was an expansion of medical school faculties and certainly of medical schools. So a lot changed with the establishment of that law. It wasn't until the early 80s that 5 years of residency training was actually required. And there were some four-year programs. I'm the product of a four-year program that was actually an experiment done in the late 70s. Weren't many of them, and they didn't last very long. I'm not sure how that reflects on me personally, but I'm not going to say. Some of you may remember the IL 372 regulation and the path audits of about 20 years ago, which had a huge impact. And this was really the basis for faculty being present in the operating room for the so-called critical parts of the operation in order to bill. And then I think everyone's well aware of duty hours requirements, and I'm going to say a little bit more about that later, but I really don't want to focus too much on duty hours. So if you look at surgical training today, it's fixed duration. Residents today do more operations than they had done in the past. I'll show you some data in a bit, but the case mix is very different. We still talk about progressive responsibility during residency, but autonomy is clearly not the same as it was in the past. A few words about that as well. We know about the information age and the effect it's had on all of us, and certainly there have been changes in societal expectations and values, as well as politics that have influenced surgical training as well. So let's back up to medical school, and I just want to spend a few moments talking about why medical students pursue a career in surgery. So these are really the reasons that have come from a variety of surveys and observations. So it's the time and duration of exposure on a surgical clerkship, the development of mentoring relationships, experience, good or bad, on that rotation, and an individual's personal characteristics. Some people just want to be surgeons, and others, no way. So we just have to recognize this. Here's some data from the AAMC of graduates from medical school in 2015, and I highlighted the three top areas that graduating students said influenced their decision as to what their initial career choice would be. And those were fit. That was sort of like, yeah, I really like this. You know, it sort of seems to fit me and my personality. Role models and lifestyle. Okay, not too surprising. Interestingly, debt, which is talked about a lot, at least no one would admit that it was higher than it is on this list. So one of the problems we have to face is that medical schools do not adequately prepare students for residency training. Okay. Attrition, a problem in surgery residencies, attrition being about 3% per year, decreasing as one progresses along in residency. And this is a national figure, by the way, now from a study about 10 years old. And it seems to be related to exposure during medical school. Okay, so if you have a broad experience, you really get a good sense of what it's like to be a surgeon. On the other hand, if it's a very truncated experience, very short time on surgery clerkships, and that's all you have, you may have a very different exposure, and it's much more limited. You're exposed to fewer people, probably exposed to a fewer number of teachers, and you may not encounter the better teachers during that rotation. Lifestyle is an issue, and clearly lack of time in the operating room. So if you don't see what surgeons do, and you're not interested in it, it's probably not going to work too hard. So let's spend a moment talking about what are the goals of residency training. And I'm going to try and look at this from the perspective of the resident. Okay, so what do you want when you're done, right? You want to get a good job, and you want to be ready for practice. You'd like to do these other things as well. You'd like to achieve competency or proficiency in technical and non-technical skills. And you want to establish the foundation for your continuous professional development, the lifelong learning aspect of what you'll do in your career. And I would pose that most people want to become board certified. It's a mark that everyone uses as a benchmark, if you will, for the adequacy of your training, the quality of your training program, and your own personal achievements. There's some other aspects, though, that are exceedingly important. You want to increase your professional and ethical behaviors. You learn a lot of this on the job. You may pick up some of this more formally, but by and large, much of it is experiential learning. You need to refine interpersonal and communication skills, develop those tendencies that you're going to need for practice-based learning throughout your career. And you need to learn how to thrive in a systems-based environment, the team-based care that we're all exposed to at a regular time. How do you do that well? How are those interactions made, and how effective are they? And so these really roll up together, okay? The professionalism, the communication skills, the team-based care, all very much interrelated. We know about skill acquisition. One moves from being a novice in medical school to hopefully being at least competent and hopefully in some aspects proficient by the time you finish residency. But we also know from this Dreyfus model of skill attainment that it doesn't stop at the completion of your training. So once you develop competency, you move on as you gain experience and you practice more and more to proficiency and eventually to expertise. Along the way of that professional development, beginning medical school and going on into practice, you find yourself in a position where supervision, high in medical school, once you get out to practice, clearly relatively low. And your authority and decision-making is the exact reverse of that. So authority and decision-making tends to be relatively low early on in your medical career and then increases as time goes on. Well, what are some of the characteristics for success? You know, how do you end up with achieving those goals that I spoke of just a few minutes ago? Well, these are some of the characteristics that I think we would all agree on. You want to be competent. You need to have grit. You know, grit is sort of the product of passion, perseverance, and resiliency. You need to maintain your well-being, and I think there's an increasing understanding of the importance of maintaining your well-being, because avoiding burnout, which can happen if you don't pay attention to your own health and your own mental health as well, can lead you to be a dropout and probably relates somewhat to attrition. And then there are the other aspects that I mentioned before about professional and ethical behaviors and communication skills, and I highlighted them here because these are the types of things that you either do very well and learn very well, or if you can't and you fail, are really problematic. And they can be problematic not only for you during the course of your training, but usually that problem continues on into practice. So really doing a good job of modeling your professional and ethical behavior well and learning how to communicate with others is extremely important. Now, my chair, Dr. Cernik, I think you remember Dr. Jessup, right? Yeah, so he had 5 very simple rules. And so if I could just emphasize to you one thing that hopefully that you'll remember from this is that it's this simple set of characteristics. So he always said if you wanted to thrive in residency and do well afterwards, you needed to stay awake, pay attention, study, go to the conferences, and give it your best. Pretty simple, okay, but very wise. Well, let's talk about some of the challenges in resident education today. I mentioned already the problems with surgical exposure and experience in medical school. We know about the effect of duty hours and how that's reduced time in training, with probably more emphasis on the decrease in training in emergent care situations, less experience with continuity of care. Okay, so you're not there to see the natural history of disease, the spectrum of disease, and the consequences. You get a much more truncated experience. Or what we do is we often cobble together experiences. So you may see a patient preoperative with one problem, another patient that you operate on, same problem, different patient, and then the third encounter is after the operation, same problem, now a third patient, and we try and cobble that experience together and say, okay, you now understand the spectrum of care across the entirety of the perioperative time. Not always true. So that's a problem we have to deal with. There clearly have been changes in attitudes, and this reflects on autonomy in the operating room. More on that later. We have to deal with the explosion of information, and it may be that the explosion of information in part accounts for why so many residents want to go into a specialty practice afterwards. And by the way, that's not new. The numbers have increased, but not by as much as one would think. So if you look back into the 1980s, as the number of people that go into general surgery as opposed to go into a specialty, the ratio then was about 60–65% went into a specialty. So the majority of people have been going into another specialty, a subspecialty of general surgery, if you will, for quite a while. And then there are changes in technology and techniques, much like information, things that we need to keep up on and we need to deal with. And one of the challenges has been with minimally invasive surgery is teaching less open operations that are done open and are done much less. Specialization in general surgery, I mentioned that. You narrow your experience and your field of expertise. There are some conflicts about the interactions between specialists and subspecialists, not necessarily as much in training, but how you train individuals for those two particular career paths. They can be very different. We know that there are variable training outcomes at different institutions. And not only do we have the stress of reduced duty hours, but if you think about some of the other requirements that are made of residents serving on committees and participation, things that are important, very much important for your career, but take more of your time away from clinical care. So again, something that we know we have to interject into the training paradigm, but yet we may not have figured out how to do it efficiently and without subtracting from the amount of clinical care that's happened. So with that in mind, I hope this is not your reaction, okay? And I hope this is not your reaction. So let's go on and talk a little bit about, how do we actually get you ready for practice? I'm going to try and show some data and really emphasize these five topics: knowledge, experience, your confidence and dedication, and judgment. So what are the data? We know there have been lots of articles, some based mainly on opinion, others based somewhat on surveys, that point out that residents don't seem to be ready for practice. Okay? So let's explore knowledge, something that I think we would all agree on is extremely important to be practice ready. So these are some data from the American Board of Surgery written exam results, the QE, and I want you to focus on the green bars. Okay, so if you notice here, that's the first time taker pass rate, okay, or in this case, the fail rate, excuse me. And you can see that over this 6-year period of time, there's a relatively consistent fail rate, pass rate, however you want to look at it, but the fail rate tends to run about 12 to 13% per year. If you then look at the oral examination over the same period of time, a little more variability, and again, focusing on the green bars, the first-time takers, we can see that certainly for the last year, that fail rate has dropped off to about 16.5%, and I can tell you preliminarily for 2017, it looks like it's going to be a fail rate that's even a little less than that. Now, this is a diagram that shows you where all of the residencies fit in relationship to what the RRC for surgery uses as the standard. And their standard, one of their outcomes that's important for programs to meet is having 65% of your residency graduates over a 5-year period of time pass both the written exam, the QE, and the oral exam, the CE. So where you want to be here is in the right upper quadrant, okay? So this is the good box, okay? You're above that threshold in both areas. You miss if you're over here or down here, and this is the problem quadrant, okay? This is where you miss both standards. Now, interestingly, if you watch this over time, there's movement from the left side here back and forth. There's movement up and down. There's relatively little movement out of here. Okay? So these tend to be the programs that we all struggle with and that struggle staying afloat. So fortunately, that number is relatively small. Experience. Well, when we think of experience, we often think of the popularization of the 10,000-hour rule for practice and deliberate practice developed by Anders Ericsson and popularized by Malcolm Gladwell in this book, The Outliers. And if you look at how that relates to surgery residency and you look at the time spent per week, the number of weeks per year you work, assuming that you have a month off, you do this for 5 years, and the fudge factor there of 0.7% is because of some non-clinical rotations where operations are done less commonly, and patient care may not be as strong. You really beat that 10,000-hour rule. The problem is when you think of it from a technical side, it's clearly much less than that. It's more like 3,500 to 4,000 hours. So you don't quite make it there. It's suggesting that the experience that you've gained throughout residency is not the experience that you may need if you're going to satisfy this rule of deliberate practice. So here's a comparison of two studies, one based on chief residents completing their training in 1989, and the other more current, a study we did looking at operations done by chief residents 2011. Now, you can note at least in the top 5, not a lot of change. Okay, same top 4 operations, only they move a little bit, and clearly the numbers which are increased, that's what's highlighted in yellow. And then we see the appearance of some new operations, colonoscopy and upper endoscopy. This is probably because of the mandate by the American Board of Surgery and the RRC. And we see some operations that have gone away from this list: laparotomy, mastectomy, fem-pop bypass, and common duct exploration. Okay, so clearly an increase in volume, but a decrease in the number of, in the types of operations done. If we look at this a different way and now compare operations done at least 20 times reported in 2005 compared to those in 2011, you can see that there's been an increase in operations done that frequently, but it's relatively small. So we've gone from 7 operations done at least 20 times during residency on median, now this is a median, not on average, to 9. And if you look at operations done at least 10 times, there's virtually been no change over this period of time. So recognizing this problem really hasn't resulted in much change in behavior. Confidence is often what's pointed out as lacking in surgical trainees. And so this is a survey that the Board of Surgery conducted in 2014, a 5-year sample of more than 4,000 graduates. And it looked and asked them about their confidence. And if you would just focus on the green and the blue parts of these pie graphs on both sides, you can see that regardless of whether you went into general surgery practice right out of training or you went into subspecialty training and eventual practice, your confidence level was relatively high. Now, looking at this a different way, this is a study done by Mark Friedel and the APDS about level of comfortability among residents. And the good parts here, the more comfortable parts of declaration by the residents are in the sand color and the red. And you can see that if you look at the more commonly done and perhaps less technically demanding operations, level of confidence or comfortability in this case is relatively high, and as one moves to operations that are done less frequently, no surprise, that level of comfort drops. Now, duty hours had some other effects rather than truncating training time, and this is one that I think was unanticipated, but in many ways led to some of the changes that will be implemented this coming year. And this shows how residents in various disciplines either did not report their duty hours correctly, the false reporting, which is on the top, the sort of the light-colored bar, and whether they were non-compliant, the bottom part of the bar. And here in the middle is this is the average for all respondents, and look where surgery is. So we led the pack, and this is one where you don't want to be the leader. Okay, so a lot of false reporting, a lot of non-compliance. You know, clearly these regulations were not having the desired effect. That, along with others who recognize the problems associated with duty hours and some of the restrictions imposed on the last iteration in 2011, decided to conduct the first trial. Were you all involved with this in the first trial? Were you control or were you? Control. Yeah, so you were control. You didn't have the opportunity to be in the group that got the relaxed rules. But when this was examined, here's what was found. So no difference in patient outcomes, the quality of education, or resident well-being. And again, these are reported by the residents participating in the study. There was clearly some positives listed for you here, and negative, no surprise, with more restricted duty hours. There was more time with family and friends. And so this is what really in many ways led to a sea change in research to actually make decisions about factors that affect residents and don't necessarily affect patient care. Well, the last thing I want to bring up here is another quote. I think most of the faculty in the room have heard this or used it on multiple occasions, and that's good judgment comes from experience, and experience comes from bad judgment. So it's highly suggestive that for us to improve our judgment over time does take experience, and there's a close link there. So we often hear of the surgeon as captain of the ship, and I want to pose this as the ship that we often captained 25 or 30 years ago. Relatively simple. Okay, it got us where we wanted to go. Okay. We were in control, and it was pretty easy to navigate. We were in charge. And this is the ship that we command today. So clearly, much more reliance on a large number of people doing a portion of what needs to be done in patient care. Coordinating all of these individuals, that team coordination, if you will, is really the key. Now, I mentioned a little bit ago that a large portion of surgery residents go on to additional subspecialty training, and currently that's about 75%. Interestingly, this has been quoted as high as 85%. It's actually been dropping over the last 2 years. So we actually track that at the board. Whether you go directly into practice or not, you do additional training. Eventually, it leads to certification, and then it takes you into the maintenance of certification pathway. And depending upon where you practice, the needs that you will face in your practice will be different. So if you're in an urban area, clearly much more involved with abdominal and alimentary tract surgery than if you're in a more rural area. And this, by the way, is as a percentage of your practice, And clearly, as you move away from urban areas, a much greater emphasis on endoscopic skills. This photograph in response to the New Yorker cover of about 2 months ago is another factor that I think we clearly have been considering as one looks at surgical training and what people choose to do in practice. And actually, this is one of my favorites because I think it really is much more emphatic about what some of the needs are in today's environment and how we have to adjust our training for those particular needs. So let's talk about what needs to change. Well, let's start with medical schools. They need to provide better and more uniform preparation for the transition to residency. So transitions are becoming exceedingly importantly recognized as critical to what we do. Education needs to be more learner dependent. We often use the term spoon feeding. Learner dependent can still be spoon feeding, but perhaps then it's more responsibility on behalf of the resident to hold on to that spoon that they're being fed by. Improved competency-based assessment tools are needed. I'll show you an example of that in just a bit. And faculty development must become a priority. We know that residents need and want exposure in the operating room early in training, and that they need to be entrusted. Okay, so that's clearly a key. Structured plan, again, for transition from residency into whatever practice environment that you're going to go into, whether it's more training or whether it's directly into practice, those pathways are needed. And general surgery residencies should focus on training general surgeons. So it's very interesting when I hear the discussion that goes on about how we should train surgeons, there's always this divide about, well, we should train people that do general surgery so they can go out into practice, and another group that says, well, that's not what most of them do, so we should train them to go into a subspecialty. So I think if you look at the big picture, the largest percentage of surgery residents that pursue a next step in their career is really general surgery. It's about 25%. And while all of those specialties add up to 75%, if you begin to break them down into their various components, transplant, oncology, critical care, et cetera, those numbers become much smaller. So we often group them together and say, well, they're all the same, but they really aren't. And I think we all recognize that, and we need to understand it and adapt to it. Community hospital experiences were often retracted when duty hours came around, and that was problematic, and these need to be restored or expanded. It's a different experience. I was speaking with some of the residents yesterday about this, and I think it's one that tends to be very valued by the residents. We need to coordinate our efforts to improve residency training. Oftentimes this is done by various organizations without doing that, and working in a vacuum doesn't go very well when you realize you've got to get others to help you when you're finished. And the relationship between the residencies and fellowships really needs to be clarified. So I think we have an evolution in training that we need to adapt to. So the thought that you do your 5 years and you go out into practice and you're done is an old concept. I think if most of us would think back as to how it was in the good old days, if I could use that term, you were still learning, you were still talking to your partners, you were still being watched by your more senior associates, and you were still talking to people about the tough cases. That hasn't changed. I think what has changed is the demands on time that everyone has in their practice now have really truncated those experiences and made them more evident as taking time away from those practice demands. And I think that's where the root of the problem really lies. And most importantly, we've got to recommit to our obligation to provide high-quality care to meet the needs of the public. That's really why we're all here. So what improvement efforts are going on? So pre-residency preparatory courses are starting to expand. Okay, there's been one put together by the program directors and the college, and this is now expanded into more than 60 medical schools. And in addition to that, there are other residencies that have their own programs. Defining the curriculum, we've done that with the SCORE curriculum. That outline is updated every year. We need to embrace competency-based education. And that can be measured in a number of ways. One aspect of this is more simulation to prepare you better for when you go into the operating room, and to define certain entrustable professional activities, or EPAs. And whenever I'm asked about EPAs are just one more measurement tool. The only difference is they're sort of a roll-up. So rather than separating things like the milestones and the competencies due when they're put on a piece of paper, the EPAs really push that all together and look more at behaviors that you're expected to master in order to be entrusted to do things with less supervision. We clearly need to adjust training to accommodate career plans. And I put a green checkbox here because there is the flexibility and training option that the board has made available that some people take advantage of, and it allows you as a resident to be able to concentrate your experience in an area of eventual practice for the last 3 years of your training. We need to improve the efficiency of learning and incorporate skills sometimes in the past held out for those who did more specialty training, that's complex, minimally invasive surgery, et cetera. We need to incorporate those into general surgery care. And I want to emphasize again the importance of coaching and mentoring. This is becoming increasingly recognized as important, not just for trainees, but also for when individuals get into practice. And the real question here is whether not only should mentoring be done, I think we all agree it should, But now the question is, how do you measure it, and how do you measure its value and decide where it fits into that scheme of training and post-training experiences? This is from that same survey I showed you earlier about confidence, but in this particular question, graduates, whether they went directly into general surgery or into a subspecialty, were asked about their satisfaction with their training. And once again, the green and the blue, you can see that most people in both segments were relatively satisfied. Message here, if we're going to make change, don't screw it up. Now, I did want to show you one data tool that's out there that I think we'll hear more about in the future, and this is called the SIMPL data collection tool. This is a cell phone-based assessment that's pushed out to both the resident and the faculty member after an operation. And this is just a pilot study that was done and reported last month at the American Surgical Association. It involved about 17,000 restaurants and thousands of surgery residents and hundreds of faculty. I'm not going to show you all the data from this, but I did want to show you this one piece, and this is measuring autonomy and guidance with the so-called Zwisch scale, which divides categories of autonomy into 4 different ones: show and tell, I think you know what that is, active help, passive help, and supervision only. And with passive help or supervision only, that's called meaningful autonomy. So as the investigators measured this and looked at the Zwisch rating and used the bar of active help or show and tell as being lack of autonomy and autonomy being supervision only or passive help, one can see a progressive rise in autonomy from training in the PGY 1 year over on your left to the PGY 5 year over on the right, and that meaningful autonomy increases from about 15% to 65%, 66%, excuse me. As we finish up, the last thing I want to focus on are some of the evolutionary influences that we have to adapt to. We know that general surgery has been altered by disease prevalence and change, intensity of care and management. The operative experience, while it may be rich, is different today. Knowledge has expanded, new specialties have emerged, expectations have changed, and autonomy is less common. So as Darwin pointed out, failure to adapt leads to extinction. So we need to make that change. Now, we often talk about thinking in the box or thinking outside the box, and I would pose that it's difficult at times to think outside the box, but perhaps what is more productive is expanding the walls of the box. Okay? We're always going to have restrictions. We will always have regulations. But thinking about how one can modify those and work within those constraints to deliver education effectively is exceedingly important. And I'll end with this final quote that education is not the filling of a pail, but the lighting of a fire. So I want to thank you all for your attention this morning. Dr. Stewart, thank you for your invitation, and I'd be happy to answer any questions if we have time.
Questions for Dr. Malangoni?
Yes.
I have one question. So I was born in the Soviet Union, and I learned that if some activity is not rewarded directly, like is not paid directly for trying to do it very good, this activity may extinguish. So do you think that the attending surgeon should be paid directly for teaching, not just for doing cases? Because that he will be or she will be more interested in teaching residents instead of like doing 5 cases a day and then go home.
You know, so we're talking about university-based programs, you know, primarily. So there are some universities that have dollars to distribute to the faculty for teaching purposes. Generally, those dollars are relatively small, and sometimes what